Emergency departments across the Midwest are seeing something this summer that most physicians have rarely encountered in this volume. A parasitic infection that most people have never heard of, producing symptoms that look enough like a stomach bug to be dismissed, until the third week, when it becomes impossible to dismiss any longer. The parasite is called Cyclospora-specific. As of this week, nearly 7,000 confirmed or probable cases have been reported across 34 states. That is more than double the total case count for all of last year. The CDC has issued a formal health alert. A multi-state outbreak has been identified in Michigan, Ohio, West Virginia, and Kentucky. And the source, likely fresh leafy greens, has not been fully confirmed, which means exposure is still ongoing. What doctors are seeing is patients who got sick 2 weeks ago and assumed it would pass. It has not passed. And many of them have already been to a clinic once, been told it was probably a virus, and sent home without the specific test that would have caught it. This is what cyclosporiasis actually looks like, and why it keeps getting missed. The first thing that surprises most patients is the delay. They ate something contaminated, a salad, a garnish, something raw, and felt completely fine for a week. Then, somewhere between 7 and 10 days after the meal they have long since forgotten, the symptoms began. That incubation period is the first reason cyclosporiasis gets missed. By the time the diarrhea starts, the food responsible is a week in the past. No one connects the two. The patient reports being sick with no idea how they got sick. The clinician, without a specific exposure history pointing to produce, defaults to viral gastroenteritis, because that is the most common cause of acute diarrhea, and it requires no specific testing to treat supportively. The diarrhea itself is distinctive to clinicians who know what they are looking for. It is watery and explosive. Those are the exact clinical descriptors used in CDC documentation. It comes in sudden, urgent waves rather than continuously. Between episodes, the patient may feel relatively normal, well enough to go to work, well enough to think they are improving. Then another wave hits. This relapsing, intermittent pattern is not typical of norovirus, which tends to be relentless for 24 to 48 hours and then clears. Cyclospora cycles. It comes and goes, and it does this for weeks. The abdominal cramping that accompanies the diarrhea is significant. Patients describe it as severe, sudden, diffuse lower abdominal pain that arrives with urgency before each diarrheal episode. Between episodes, there is a persistent bloating and a general abdominal unease that does not fully resolve. The gut feels wrong even when it is not actively producing symptoms. Nausea is present in most cases. Vomiting is less consistent. Some patients vomit repeatedly, others experience nausea throughout without vomiting at all. This inconsistency means patients who vomit assume they have a bug, and patients who don't assume it is something they ate that disagreed with them. Neither group, in the early days, is thinking parasite. Loss of appetite follows and is disproportionate to the acute symptoms. The gut is inflamed. Eating worsens cramping. Nausea makes the idea of food unappealing. But unlike viral gastroenteritis, where appetite returns within days of the acute phase, cyclosporiasis suppresses appetite for weeks. Patients who have been sick for 3 weeks and have lost significant weight without trying, 5, 8, 10 pounds, are presenting in clinics now. The weight loss is the signal that something beyond a standard gut virus is at work. The fatigue is what most patients find hardest to explain, and what most clinicians find hardest to attribute to a gastrointestinal infection. It is profound. It is out of proportion to the diarrhea. It persists, and in some patients worsens, as the acute digestive symptoms begin to cycle into the quieter phase. People who consider themselves healthy and energetic describe being unable to complete a normal day's work. Not because they are running to the bathroom constantly, but because their body feels emptied of reserves they cannot replenish. What is happening physiologically explains this. Cyclospora-specific invades the epithelial cells of the small intestine, the cells responsible for absorbing nutrients from digested food. While those cells are infected and inflamed, absorption is impaired. The patient may be eating, attempting to, but the nutrients are not getting through. They are losing fluid and electrolytes through the diarrhea. They are running an immune response against a parasitic infection. They are doing all of this simultaneously while their intestine is functionally compromised. The fatigue is the body under multiple simultaneous deficits with reduced capacity to address any of them. Doctors seeing patients in the 3rd or 4th week of illness are describing a presentation that looks almost post-viral. Exhausted, pale, weight reduced, functioning at a fraction of normal capacity, in people who had no other health issues before this began. The reason so many cases are being missed at first presentation comes down to one specific laboratory failure: the standard stool test for ova and parasites. The routine test ordered when a clinician suspects a parasitic infection does not reliably detect Cyclospora. The parasite requires a modified acid-fast staining technique or PCR-based molecular testing to be identified. Neither of these is included in a standard ova and parasite examination unless specifically requested. The CDC Health Alert issued on July 14th explicitly instructs clinicians to specifically request Cyclospora testing on stool specimens rather than assuming routine ova and parasite examination will catch it. PCR-based testing is recommended where available, as it significantly improves detection sensitivity. This means a patient who presents with 3 weeks of relapsing watery diarrhea, who has a stool test ordered, and whose doctor does not know to request Cyclospora-specific testing will receive a negative result that does not rule out the infection. The test came back negative. The parasite is still there. The patient is sent home again. If you are being evaluated for a prolonged gastrointestinal illness this summer, particularly in one of the 34 affected states, the words to say are, please test specifically for Cyclospora cayetanensis, not just ova and parasites, Cyclospora specifically. Treatment changes everything and does so quickly. Trimethoprim sulfamethoxazole, known as Bactrim or Septra, is the antibiotic that clears Cyclospora infection. Patients who have been symptomatic for weeks typically begin feeling significantly better within 3 to 5 days of starting the correct antibiotic. The diarrhea reduces. The appetite begins returning. The fatigue starts to lift. Without it, the illness continues. Some healthy individuals will eventually clear the infection on their own, but untreated cyclosporiasis has an average duration of 6 to 7 weeks, with cases extending longer. Antidiarrheal medications like loperamide manage the symptom. They do not touch the parasite. Probiotics, dietary changes, rest, and hydration support the body. They do not clear the infection. The only treatment that works is the specific antibiotic, and the only way to get it is a confirmed diagnosis. For immunocompromised patients, those on chemotherapy, living with HIV, taking immunosuppressive medications after transplant, untreated cyclosporiasis can become severe and prolonged. The immune system cannot contain an infection. It does not have the tools to fight. In this population, early aggressive testing and treatment is not optional. Hydration is the immediate priority for anyone symptomatic. Watery diarrhea several times a day, compounded by reduced appetite and nausea, produces fluid and electrolyte losses that compound the fatigue and can, in older adults and young children, become medically dangerous. Oral rehydration, water with electrolytes, not just plain water, is more effective than plain fluid replacement because glucose in the oral rehydration solution enhances sodium and water absorption in the parts of the intestine not affected by the infection. Sports drinks are a reasonable approximation if oral rehydration salts are not available. Plain water alone is insufficient for replacing the electrolyte losses from repeated watery diarrhea. Seek care promptly if the diarrhea is severe enough to prevent keeping any fluids down, if there is blood in the stool, which is not typical of cyclosporiasis and suggests a different or additional pathogen. If the person is elderly, very young, or immunocompromised, or if dizziness on standing suggests significant dehydration. Cyclospora is not transmitted from person to person. This is one of the most important facts to understand about this outbreak. You cannot catch it from someone in your household who has it. You cannot catch it from a colleague who is sick. The only route of transmission is contaminated food or water, specifically food or water that has been contaminated with human fecal matter containing Cyclospora oocysts. This means the risk in your environment right now is the produce in your kitchen, not the people around you. The recall of Taylor Fresh Foods iceberg lettuce products is in effect. Market-side brand iceberg salad and shredded lettuce sold at Walmart with Best By dates through early August 2026 are included. Checking the produce in your refrigerator against current recall information is a concrete protective step. Washing produce reduces but does not eliminate risk. Cyclospora can adhere to leaf surfaces and survive standard rinsing. Cooking destroys the parasite completely. The highest risk foods are those eaten raw: salad greens, fresh herbs, raspberries, snow peas, green onions. During an active outbreak of this scale, cooking produce that can be cooked and being selective about which raw greens you consume is the most practical protective measure available while the source investigation continues. Doctors are seeing patients who have been sick for 3 weeks and are only now getting the right test. Patients who were told it was a virus and to stay hydrated and are now back because staying hydrated did not resolve a parasitic infection. Patients who did not know the standard stool test would miss it. The gap between what is happening and what patients know to ask for is the problem this summer. The parasite is treatable. The illness resolves quickly with the right antibiotic. The weeks of suffering that precede the correct diagnosis are the part that did not have to happen. If you have had relapsing watery diarrhea for more than a week, with cramping, fatigue, and loss of appetite, in the context of having eaten fresh produce in the past month, ask for the test by name, Cyclospora-specific. Specifically. The difference between that request and the standard order is the difference between a diagnosis this week and 3 more weeks of waiting for something to get